Nephrotic syndrome. It's a clinical state characterized by heavy proteinuria more than 3.5 gram per deciliter per 1.73 meters square of the surface area of the body, and hypoproteinemia. Notice that there is smaller amount of proteinuria in children, more than 2 gram per deciliter, because of the smaller body surface area. Nephrotic syndrome is also associated with edema, hypocalcemia, hypokalemia, hypercholesterolemia, and dyslipidemia. The pathological classification of nephrotic syndrome: number 1, minimal change disease. It is the most common cause in children, 80%. Number 2, focal segmental glomerulosclerosis. It is the most common cause in adults, 40%, and the second most common cause in children. Membranous glomerulonephritis, the second most common cause in adults, 35%. Number 4, mesangial proliferation. Number 5, membranal proliferative glomerulonephritis. Etiology: all types of glomerulopathies can produce nephrotic syndrome. This may either by primary glomerular diseases, idiopathic, or secondary to other diseases. Primary, it represents 90% of the childhood cases. It's idiopathic with absence of systemic disease. Secondary to systemic disease, we have 3I and 3M. Eye infections such as bilharzia, malaria, syphilis, streptococci, hepatitis B, C, and HIV. Iatrogenic, due to penicillamine, gold, NSAIDs, heroin, interferon, immune, SLE, and Henoch-Schönlein purpura. M. Metabolic diabetes mellitus and amyloidosis, malignancy, lymphoma, multiple myeloma, metals, mercury and lead. Others: Alport syndrome, toxemia of hyperpregnancy, sickle cell disease, and renal vein thrombosis. Pathogenesis: proteinuria, hypoalbuminemia, edema, dyslipidemia, hypocalcemia, and hypokalemia. Proteinuria is due to increase in permeability of the glomeruli to protein as a result of structural changes in the glomerular basement membrane, whether due to increase in the pore size or neutralization of the charge, allowing negative charged albumin to pass. Hypoalbuminemia is secondary to proteinuria and anorexia malabsorption due to GIT edema. Edema: decreased plasma oncotic pressure as a result of hypoalbuminemia and from salt and water retention, which occurs due to decreased sensitivity to erythronatriuretic peptide, stimulation of RAS system, tubulointerstitial inflammation, which accompanies proteinuria, leading to defect of sodium excretion. Number 4, dyslipidemia. It's very common in nephrotic patients. Marked elevation of cholesterol, LDL, triglycerides. HDL cholesterol level is usually normal or reduced, so it's accepted that nephrotic patients, with the exception of those with minimal change diseases, they have 5-fold increased risk of cardiac death. The mechanism is unclear, but it can be due to 5 reasons: associated hypothyroidism, increased hepatic synthesis of lipoproteins, which is stimulated by reduced plasma oncotic pressure, reduced catabolism of lipoproteins due to inhibition of endothelial lipoprotein lipase activity, decreased albumin carrying capacity to lipids, and finally urinary loss of high density lipoprotein HDL3, reduced activity of lectin cholesterol acetyltransferase LCAT, leading to reduced levels of cardioprotective HDL2. Hypocalcemia, due to hypoalbuminemia and urinary loss of vitamin D binding proteins, leading to hypovitaminosis D, but it's usually with normal ionized calcium. Hypocalcemia in nephrotic syndrome, it is the total calcium level, while the ionized calcium level is normal. Hypokalemia is due to high aldosterone level, diuretics, steroid therapy, vomiting, secondary to edema of gastric mucosa. Clinical picture and complications: edema, hypoproteinemia, hypokalemia, hypercoagulability, renal failure, no hypertension, no tetany, no hematuria. There are 8 points. Number 1, edema. It is a major presenting symptom, and it's clinically detectable when the fluid retention exceeds 3 to 5% of body weight, of gradual onset. Periorbital edema is often the initial symptom, particularly in children, and it's usually noticed in the morning. Adults tend to present with peripheral edema in the ankles. It's gravity dependent, so ankle edema in the upright position. Generalized edema anasarca may develop with ascites, pleural effusion, and rarely with pericardial effusion. The edema is soft and petting. Edema of the genitals, scrotum and labia and GIT may be seen. Abdominal pain occurs due to rapid formation of ascites, which may be complicated by spontaneous bacterial peritonitis. Mesenteric thrombosis may play a role. Shortness of breath in nephrotic syndrome is often related to pneumonia, pulmonary embolism, which is breathlessness with chest pain, pleural effusion, breathlessness without chest pain. Pulmonary edema doesn't occur in pure nephrotic syndrome if there is no additional cardiac disease. Number 2. Hypoproteinemia. Muscle wasting, negative nitrogen balance, and it is masked by edema. It's very common. Osteoporosis, urinary loss of IgG and complements with malnutrition leads to recurrent infections. Bacterial infections are frequent in children. The most common infection is peritonitis. The most common organism is Streptococcus pneumonia. Other organisms are like H. influenza, E. coli, beta-hemolytic streptococci. Viral infections may be observed in patients receiving steroid and immunosuppressive agents. Chickenpox is often observed in young children, which is life-threatening. We also notice loss of transferrin leading to anemia, loss of thyroid-binding globulin leading to hypothyroidism, loss of various drug-binding proteins leading to increased toxicity of drugs. Number 3. Manifestations of hypokalemia. The normal level is from 3.5 to 5 milliequilibrium per liter. The manifestations are muscle weakness up to paralysis, arrhythmia and ECG changes, hypokalemic nephropathy. Number 4. Manifestations of hypercoagulability. 10% of nephrotic adults and 2 to 3% of children will have clinically apparent thrombotic complications. It can be venous or arterial thrombosis, for example, DVT, pulmonary embolism, myocardial infarction, renal vein thrombosis, and it's characterized by hypertension, palpable kidney, macroscopic hematuria, loin tenderness, and raised creatinine. Membranous nephropathy is more frequently complicated by thrombosis other than the causes of nephrotic syndrome, but the reason is unknown. Causes of increased thrombotic risk. It's uncertain, but we have 5 causes. Physical factors, immobility, hemoconcentration, increased blood viscosity, urinary loss of antithrombin 3, polycythemia secondary to steroid therapy, abnormal endothelial function related to dyslipidemia, and finally enhanced platelet function with increased von Willebrand factor, altered membrane lipids, and enhanced prostaglandin metabolism. Number 5, we have no hypertension in pure nephrotic syndrome. Blood pressure is usually normal, but it may be elevated if the cause was diabetes mellitus or collagen diseases in case of nephrotic, or steroid therapy, or development of renal failure or renal vein thrombosis. And that's why a very important MCQ note that atenolol will be less useful than other drugs in the treatment of nephrotic syndrome because it's used in treatment of hypertension. No tetany. Number 6. Hypocalcemia of nephrotic syndrome is characterized by low total calcium but normal ionized calcium. No hematuria. Macroscopic hematuria is observed in 3% of the cases. Number 8. Renal failure. Acute renal failure and chronic renal failure. Acute renal failure, it occurs if hypovolemia was severe enough to cause acute renal failure, but it's very rare, but it can be seen in severe, rapidly developing nephrotic syndrome, particularly in adults, crescentic change in patients with membranous or IgA nephropathy, bilateral acute renal vein thrombosis, but it's very rare, excessive diuretics leading to hypovolemias in acute tubular necrosis, interstitial nephritis due to use of diuretics or NSAIDs. Chronic renal failure, with the exception of minimal change disease, nephrotic range proteinuria is associated with increased risk of progressive renal dysfunction. The risk is proportionate to the degree of proteinuria. The link between heavy proteinuria and progressive renal disease, it may be due to the severity of the underlying glomerular disorder and because proteinuria is a mediator of tubule interstitial inflammation and fibrosis. Investigations. We have urine examination, blood examination, renal function test, renal biopsy, and investigations for the cause. ANA for collagen diseases, blood glucose, hepatitis B markers, and this finishes investigations of the cause. Renal biopsy. The indications are age less than 1 or more than 10 years, macroscopic hematuria, low C3 level, renal failure, relapse, failure to respond to steroid therapy, persistent hypertension, and macroscopic hematuria. I think I have said microscopic hematuria, but so what? Biopsy is not indicated in 3 cases. Young children with highly selective protein leak, no hypertension, no hematuria, so the diagnosis will be minimal change lesion. Or in patients on drugs such as penicillamine, which should be stopped first, or long-standing diabetes was associated with retinopathy, neuropathy, and that's why we would expect diabetes nephropathy. Renal function test, creatinine and urea, they are usually normal, but in severe hypovolemia, which produce pre-renal failure, it can be increased. Or if the underlying pathology is membranous or mesangiocapillary glomerulonephritis, so we would have functional renal impairment leading to increased plasma urea and creatinine. Blood examination, serum protein. Serum albumin is decreased less than 2.5 gram per deciliter. Serum globulin is relatively preserved. Lipids, we have marked elevation of cholesterol, LDL, triglycerides. HDL cholesterol level is usually normal or reduced. CBC, we have elevated hemoglobin due to decreased plasma volume. Electrolytes, we have hyponatremia, hypokalemia, hypocalcemia. Serum complements, C3 is usually normal. Urine examination. Nephrotic range proteinuria, 24-hour urine protein measurement. We would notice proteinuria more than 3.5 gram per day. Dipstick urine protein, 3 positive, 4 positive. Urinary protein creatinine ratio, UPCR, is more than 3.5. Urinary protein selectivity and its use in pediatric practice in order to diagnose minimal change. Cameron and Blanford index. This is urinary IgG to transferrin ratio. If it's less than 0.05, it's good index and indicates steroid responsiveness, while if it's more than 0.15, then it's a poor index, usually steroid resistant. We have hyaline casts and fatty casts. Microscopic hematuria is in 20% of the cases. Treatment. Diet. We decrease water to avoid dilutional hyponatremia, decrease sodium to prevent and treat edema, increase potassium, decrease fat. Proteins, it can be increased with supplementations of amino acids, but this would aggravate and leads to progression of underlying glomerular lesions, so moderate protein restriction is advised, particularly in a case of renal impairment. Drugs. For hypovolemia, we use infusion of plasma or albumin. For edema, we use diuretics, but they are used in severe edema after hypovolemic correction. We use furosemide, 1 to 2 milligram per kilogram, or spironolactone, which may be added, but there's a problem because diuretics will lead to hypovolemia, which would lead to acute renal failure, and that's why we accept moderate edema in the patients of nephrotic syndrome and we don't treat it. Albumin, it's of beneficial effect, but it's transient because it's excreted in 24 to 48 hours. Such treatment may be necessary in a case of severe hypoalbuminemia. Drainage is used in case of refractory edema with serious effusion. Hypercoagulability is treated by mobilization, long-term oral anticoagulant warfarin, antiplatelets such as low-dose aspirin and dipyridamole. The effectiveness of heparin may be impaired by concomitant antithrombin 3 deficiency. Infections, pneumococcal and varicella vaccination, early detection and aggressive treatment of infection rather than long-term antibiotic prophylaxis. Hyperlipidemia, we give atorvastatin 10 to 20 milligram per deciliter. Steroid therapy. It's the cornerstone of the management of most children with nephrotic syndrome. The initiation of the therapy may be delayed for a week, as a spontaneous remission occurs in 5% of cases within a week. The dose is divided into 60, 40, 20, 15, 10, 5. 60 milligram per meter square per day for 4 weeks. Then, from 40 up to 5 doses, 40 milligram per meter square alternate day, 20 milligram per meter square per alternate day, 15 milligram per meter square per alternate day, 10 milligram per meter square per alternate day, and 5 milligram per meter square per alternate day, and all of them are given for 4 weeks. Each dose is given for 4 weeks. Patients who are not in remission after 4 weeks of daily steroid therapy, they would be given 3 pulses of methylprednisolone, 1000 milligram IV. Patients who have persistence of proteinuria 1 week after this treatment, they are considered steroid resistant, and renal biopsy would be indicated. In both children and adults, if remission lasts 4 years after steroid therapy, further relapse would be very rare. 4 years after steroid therapy, further relapse is very rare. Treatment of relapse: cyclosporin, mycophenolate, cyclophosphamide, which is given orally in children and IV in adults. Treatment of steroid-resistant nephrotic syndrome: cyclophosphamide, ACE inhibitors, and ARBs, because they decrease intraglomerular hydrostatic pressure, decreasing urinary protein loss, which would decrease the symptoms of the disease. Treatment of the cause in case of secondary nephrotic syndrome, such as SLE and the other causes that we have previously mentioned. Infrequent relapsers, they have 1 relapse in less than 6 months. Frequent relapsers, they have 2 to 4 relapses in a year. And this concludes our chapter for today. Chronic renal failure. Definition: gradual irreversible deterioration of the renal function. Etiology: we have 12 points. Chronic glomerulonephritis, chronic pyelonephritis, history of fever, dysuria, loin pain, which is the most common cause. So we need to say that again. Chronic pyelonephritis is the most common cause of chronic renal failure. Number 3, diabetes. 4, hypertension. 5, gout. Hyperparathyroidism, collagen diseases, congenital like polycystic kidney, secondary amyloidosis, obstructive uropathy, stones, iatrogenic, NSAIDs, idiopathic. Diabetes and hypertension are the most common causes worldwide, but in Egypt, chronic pyelonephritis and chronic glomerulonephritis are the most common causes. Pathophysiology. It's divided into 8 points: creatinine, urea, hydrogen ions, calcium, phosphate, potassium, sodium, and water. Urea and creatinine would be increased. Hydrogen ion is increased, leading to acidosis due to decreased formation of urinary buffers and incomplete bicarbonate reabsorption. We have no tetany in chronic renal failure in spite of hypocalcemia, because acidosis will increase the ionized calcium. Calcium, it decreases, then reaches normal level, then it increases in end stage. Phosphorus times calcium equal constant. Okay, so at first calcium is decreased due to hyperphosphatemia, which increases calcium excretion with decreased vitamin D activation by the kidney. Then hyperphosphatemia, because it's a stimulus of the parathyroid hormone, it would lead to hyperparathyroidism, which would increase calcium up to normal. Then at end stage of chronic renal failure, persistent hyperphosphatemia lead to persistent hyperparathyroidism, lead to persistent elevation of calcium, which would exceed the normal level. Phosphate, it's increased. Potassium, at first it's normal because its excretion is easy, but in end stage, hyperkalemia occurs, and it occurs also in severe acidosis. Sodium, in 80% of the cases, there is hypernatremia due to activation of the RAS system, but in 20% of the cases, there is failure of sodium reabsorption from the tubular damage. Finally, we have water, polyuria, mild 2.5 to 3 liters per day due to retention of urea, which would lead to osmotic diuresis and hyperdilatation of the residual nephrons. Clinical picture. Because of high reserve of the kidney, symptoms don't appear until renal function, or the GFR, declines to 30% of the normal. More than 30% of normal GFR, biochemical evidence of renal failure can be seen, but patients are generally still asymptomatic. So it's divided into 8 points: GIT, cardiac, chest, CNS, skin, bone, blood, endocrinal, and metabolic. GIT. Due to the effect of uremic toxins, mouth, we would have stomatitis, dry mouth and tongue, ammonia smell in the mouth with bad taste sensation. Esophagus, we would have GERD, Diaphragm, hiccough due to central effect of uremic toxins such as phenol. Stomach, gastritis up to bleeding and perforation. Liver, hepatitis. Intestine, constipation. And late we would have uremic dysentery due to urea deposition in the colon. Cardiac, the blood pressure. Usually we would have hypertension in 80% of the cases due to sodium retention, and in sodium losers we would have hypotension. Myocarditis would lead to heart failure. Uremic pericarditis, this indicates end-stage renal disease, and dialysis is indicated in this case. Usually it's painless pericarditis, and it may be due to uremic toxins. Arrhythmia due to electrolyte disturbance. And you should know that the most common cause of death in chronic renal failure is the cardiac manifestations. Chest, recurrent chest infections, pneumonia, TB, bronchitis. Rapid, deep respiration due to acidosis. CNS, we would have neuropathy, myopathy, stroke, loss of concentration, convulsions, and coma. Insomnia, headache. Psychiatric symptoms such as depression, irritability, and schizophrenia. Skin, we would have pigmentation, pallor, earthy look. Pruritus due to increased phosphate, parathormone, calcification, and urea froth. Purpura and bleeding tendency due to thromboathenia. Bone, renal osteodystrophy, osteoporosis, osteomalacia, osteosclerosis, osteitis fibrosa cystica. The etiology of renal osteodystrophy is still questionable, most probably due to two mechanisms: secondary hyperparathyroidism and inactivation of vitamin D. Blood, anemia due to decreased erythropoietin synthesis, blood loss, bleeding and dialysis, and decreased lifespan of the RBCs. While BC's dysfunction lead to recurrent infections, platelet dysfunction, thromboathenia would lead to bleeding tendency. Endocrinal and metabolic. Endocrinal, secondary and tertiary hyperparathyroidism due to persistent hyperphosphatemia, secondary hyperaldosteronism, inactivation of vitamin D, osteomalacia, decreased production of renal hormones such as erythropoietin and testosterone. Insulin, two types of abnormalities may occur: hyperglycemia due to insulin resistance because it's an end organ dysfunction, or decreased insulin requirement in diabetics due to decreased insulin clearance. Decreased metabolic clearance of hormones such as insulin, FSH, LH, GH, prolactin. Decreased conversion of T4 to T3 leading to hypothyroidism. Metabolic, carbohydrate metabolism, as we have talked about the insulin. Fat, impaired clearance of triglycerides, so increased triglycerides and decreased HDL. Protein, increased catabolism, wasting of the muscles, and gout. Electrolytes, we have talked about it in sodium, calcium, and potassium. Investigations aim to prove the condition, to assess severity, and to search for the cause. We have urine examination, blood examination, renal function test, ultrasound, and investigations for the cause. Urine examination, volume, we have mild polyuria, 2.5 to 3 liters per day. Specific gravity is fixed, 1010. Casts, we have broad casts, this is very specific, and granular casts, which is not specific. Blood examination, CBC, normocytic normochromic anemia, increased sodium hyponatremia in 80% of the cases, and hyponatremia in 15 to 20% of the cases, sodium losers. Potassium is normal and it's increased in end stage. Calcium is lows and normals and high in end stage. Phosphate is increased. Hydrogen ions is increased. Renal function tests, they are impaired. Azotemia, increased urea and creatinine, and decreased creatinine clearance. Ultrasound, shrunken kidneys, loss of corticomedullary differentiation, and increased echogenicity. They become brighter. The echogenicity of the kidney is the best assessment tool, and it's assessed by comparing it with adjacent organs such as liver or spleen. The order of echogenicity from hypo to hyperechogenicity is medulla, cortex, liver, spleen, prostate. The prostate is the brightest. So the mnemonic would be my cat likes sunny places, medulla, cortex, liver, spleen, prostate. Chronic renal failure without shrunken kidney would be in 4 cases: diabetes, polycystic kidney, tumor, and amyloidosis. Investigations for the cause: blood glucose. Now we have staging of chronic renal failure. We have 5 stages of chronic renal failure. Stage 1, glomerular filtration rate. I would say GFR because I have a problem with pronunciation of R and F and L in the same word. So GFR would be more than or equal to 90 milliliter per minute. Loss of renal reserve, normal renal function, but urine and other abnormalities point to kidney disease. Stage 2, GFR from 60 to 89, mild renal impairment. Stage 3, GFR from 30 to 59, moderate renal impairment. Stage 3A is 45 to 59, while 3B is 30 to 44. I'm talking about the GFR. Stage 4, GFR is from 15 to 29, which is severe chronic renal failure. Stage 5 is less than 15, end stage chronic renal failure. Treatment: diet, water, sodium, potassium, proteins, drugs, symptomatic treatment, dialysis, and transplant. Diet: water, we increase water, usually 3 liters per day. Fluid chart, 500 cc plus volume of urine in the previous day. Sodium, decreased in 80% of the cases and increased in sodium losers. Potassium, normal, but avoid excessive potassium intake, decrease in end-stage chronic renal failure. Proteins, restricted, 40 gram per day. Drugs, just symptomatic treatment. GIT, for vomiting, domperidone, motilium, hiccup, domperidone, gastritis, ranitidine. Cardiovascular system, hypertension. We need to reach target blood pressure less than 130 over 85 millimeter mercury. The regimen is ACE inhibitors, alpha-methyl dopa, beta blockers, calcium channel blockers, or diuretic. Hypertension control has been shown to decrease the progression of chronic renal failure. Pericarditis, we perform dialysis. Arrhythmia, كتاب الكارديو. Pericarditis, dialysis. Heart failure, dialysis dilator, digital small dose, diuretics. Chest infections, non-toxic antibiotics. TB, we give rifampicin, which is the safest drug. Avoid streptomycin and ethambutol are contraindicated. CNS, neuropathy, vitamin B12, convulsions, diazepam, recurrent attacks of convulsions or coma, dialysis. Skin, pruritus, phosphate binder, aluminium trihydroxide, or we give antihistaminics. Bone, renal osteodystrophy, phosphate binder, aluminium trihydroxide, calcium carbonate, and decrease phosphate in diet. Active vitamin D, 1 alpha. Blood, anemia, we give packed RBCs or erythropoietin, Eprex, 4,000 micro 2 times per week. Then we have, for metabolic and endocrinal systems, we give sodium bicarbonate for acidosis. Hyperlipidemia, lipid lowering drugs like colfibrate and statin. Secondary hyperparathyroidism, parathyroidectomy or treatment of renal osteodystrophy. Dose of insulin in diabetics, we increase or decrease according to the case. We see the clinical picture and you may understand. Renal replacement therapy, dialysis and renal transplant. Indications of dialysis in patients with chronic renal failure, we need to see the clinical symptoms and lab. Clinical symptoms are acute pulmonary edema, pericarditis, persistent diarrhea, preoperative, coma, convulsions, deterioration of general health. Lab. When urea is more than 200 mg per deciliter, the normal is from 20 to 40. Creatinine is more than 8 mg per deciliter or more than 7 in diabetics. Normally it's from 0.7 to 1.2. Potassium more than 5.5. The normal is from 3.5 to 5.5. Bicarbonate less than 15 milliequilibrium per liter. pH less than 7.15, creatinine clearance is less than 15 milli per minute. But the techniques, complications, and contraindications, it's in another chapter. And this concludes our chapter for today.